Hey, what's up, guys? Welcome back to next episode here. I'm Dr. Jonathan Barnes. This time we're going to be talking about diabetic emergencies, especially with the holidays coming up. There'll be a lot of sweet things people are eating, and so you might encounter some of these. As usual, let's take a moment or two to review the disclaimer. All right, let's get into it. So today what we're going to talk about, I'm going to give you a little background on diabetic emergencies. We'll talk about the situation where the sugar is too low. We'll talk about sugar too high. And then I want to talk about a particularly high-risk area here, which is the refusal of the patient who has been treated for hypoglycemia and is now refusing to go to the hospital. So we'll talk a little bit about that situation. So first of all, what is diabetes? So diabetes basically is often characterized into two types. Type 1 is the kind that typically affects children and adolescents. You're typically diagnosed with it in childhood and you have it for your life. It's about 5 to 10% of the time. This basically is a result of a defect in the cells of the pancreas called beta cells, which produce insulin. And so type 1 diabetic doesn't have enough insulin, doesn't make insulin, and so they need exogenous insulin, meaning they have to give themselves insulin to replace the insulin that the body would otherwise naturally produce. Type 2 diabetes, by contrast, typically adult onset, is the majority of cases. It's usually associated with obesity or physical inactivity, although there is a genetic component to it as well. And in this case, this starts out as insulin resistance, meaning that the body has insulin but cannot use it properly. However, as type 2 diabetes progresses, often the pancreatic beta cells will burn out and these patients will become dependent on exogenous insulin. So there's some degree of overlap in later stage type 2 diabetes. And that's basically what I want you guys to understand by looking at this chart. Okay, so type 1 diabetes is a disease of disordered insulin production, okay? Whereas type 2 is disordered insulin utilization, meaning you can't use it right. However, there is some degree of insulin dependence in type 2 diabetes, so they do overlap there. Everyone with type 1 diabetes depends on insulin. Some people with type 2 diabetes also depend on insulin. So let's get into the emergencies, which is where we come in as EMS providers. So the first type of diabetic emergency you could have is the sugar is too low. Now, how low is too low? About 70, okay? Now, how are you going to know that? So you're either going to have to assist the patient checking their own blood sugar, or ALS is going to have to check it for you, or one day maybe this will get moved to BLS in New Jersey. It is in other states. Now, what are the clinical signs and symptoms you might see in someone who has low blood sugar? Well, they're listed here, okay? Now, I want to distinguish what's the early versus the later phase of this, right? So this is early. Anxiety, palpitations, tremors, numbness, sweating. You'll notice that that's pretty nonspecific, and that can be almost anything, right? So the early symptoms of low blood sugar are not that specific. These are the later symptoms, okay? So I'll just call that these are later. And these are the more serious ones. And so anyone who's confused or altered, what do we always want to think about? Checking a sugar, okay? If the patient's seizing, it could be because their sugar is low. And in the really end stage of the game, you can go into a coma and you can die from this. It is, for example, in cardiac arrest, one of the H's you think about in terms of reversible cause of cardiac arrest being hypoglycemia. Now, the treatment for this, fairly straightforward. If the sugar is too low, give more sugar. And so that can be in the form of orange juice, like a liquid. It can be in the form of those glucose tubes you carry on the ambulance. Or if the patient's awake and can eat food, they can eat a sandwich. PB&J is often one that's used because the jelly is quick sugar. The protein in the peanut butter will last a little longer and the bread's somewhere in between. Just be careful of any allergies if you're going to give them actual food, okay? But in general, if the patient's awake and alert and they can swallow and their sugar's low, they should eat some sugar. So how about the flip side? Well, what if the blood sugar is too high? How high is too high? Greater than 200 is considered abnormal. Now, there are many people who run with a blood sugar in like 300 and they're asymptomatic, and they typically are not the ones calling you because they feel fine. They don't really notice it. and that's not really going to constitute a blood sugar emergency per se. However, you can become symptomatic from it. Now, I will give one caveat at this. Without checking someone's blood chemistry, you really don't know if they're having some metabolic derangements that are putting them towards a blood sugar emergency like DKA or HHNK, which we'll talk about on the next slide. But just so you know, there are a lot of people who don't have any symptoms at all, and then there will be people who develop symptoms. I want to point out a few in particular, okay? Fatigue, nonspecific, could be a lot of things. Tachypnea. This is really important. And you may have heard of something called Kussmaul respirations, which is another type of kind of fast, long breathing. And the reason this happens is because if you have very high blood sugar and you're a type 1 diabetic and you're getting into DKA, which I'll talk about on the next slide, you're building up acid in your body, and your body tries to blow off that acid in the form of carbon dioxide by making you breathe faster. So that's really important, okay? Altered sensorium, confusion, nonspecific, abdominal pain, nausea, and vomiting. This is pretty common if you're having a blood sugar emergency because the ketones produced, the K and DKA, often makes you have abdominal pain, nausea, and vomiting. So that can be a clue, okay? Now, in general, hyperglycemia or high blood sugar does present with polydipsia, polyuria, and polyphagia. And so I have patients come to the ER and they say, Doc, I've just been peeing a lot. I'm extra thirsty. I'm extra hungry. Polydipsia is extra thirst, polyuria is extra urination, and polyphagia is extra hunger. And oftentimes that may be the first manifestation that they're getting diabetes. Now, because they're peeing so much, they will get severely dehydrated. They're losing a lot of fluids. So severe dehydration is pretty common in this. And if they're puking, that adds to even more dehydration. So dehydration is really common. Okay. Now, I mentioned DKA and HHNK on the previous slide. What does that stand for? So DKA stands for diabetic ketoacidosis. That's typically a blood sugar emergency from too high blood sugar. It most commonly occurs in type 1 diabetics because they do not have their own insulin production. If you have any endogenous insulin production, like any insulin production in yourself, you're much less likely to go into DKA. So this typically is in type 1. However, type 2 diabetics can get DKA, so I don't want to say exclusively. And then HHNK, or hyperosmolar hyperglycemic non-ketotic state, typically is more common in type 2 diabetes. The truth of the matter is the distinction between these two is not that important in EMS because you often won't be able to tell, and the initial treatment for the adult patient with this is going to be to give IV fluids. So you're going to need EMS, you're going to need IV fluid administration. And remember, why do they need IV fluids? Because they're so dehydrated from peeing all the time, and they're dehydrated because they're often having nausea and vomiting. So they really need a lot of IV fluids. That's the main treatment for this in the pre-hospital setting. There's really no role for use of insulin in the pre-hospital setting in these patients. Some people think that. They might think, oh, I should give insulin, the blood sugar is too high. In the pre-hospital setting, the first priority should be getting these patients adequately volume resuscitated with IV fluids, okay? So it's IV fluids for these patients. The insulin will come later in the hospital. Now, I want to make something clear. The blood sugar in and of itself isn't always the only emergency. I want you to think of hyperglycemic emergencies, and think of hypoglycemic emergencies like this as well, as a cry for help, meaning it's your body telling you that something's wrong. Now, it could be as simple as missed medications, but it could also be that the patient's getting infected. Maybe they have a UTI and that triggered them to go into DKA. They could be having a heart attack, right? Pregnancy can put you at risk, or maybe they were in trauma, or maybe one of these conditions interrupted their insulin supply, or maybe something happened that the patient couldn't get their meds. So there's often something underlying why someone went into a diabetic emergency. So don't get tunnel vision and just look at the glucose and focus on treating the glucose. Think about the whole picture. Why did this happen to them in the first place? And this is really important for EMS because oftentimes the clues you gather on scene are the only information we're going to get in the hospital as to why this may have happened. So really try to get as much of the information as you can about the case and think about what triggered them to go into their diabetic emergency. All right. So let's talk about refusal of medical care in diabetic emergencies. So we talked about hypoglycemic patients, you're going to give them sugar. Hyperglycemic patients, they need IV fluids. Typically, they're going to need ALS. They're going to need to go to the hospital. Okay. It's a common situation where hypoglycemia leads to the patient wanting to refuse. Why? Because what will happen is you'll give them that glucose, they'll get better, they'll be back to normal and say, hey, I don't need to go to the hospital anymore. And this happens fairly commonly. This is a fairly common EMS refusal situation, but it's also very high risk. So how do you know who is in a lower risk category who may be more reasonable to refuse? Now, I just want to put in a plug. In the past, I've covered medical decision-making capacity, about who has the capacity to refuse. I suggest you take a look at that because you should be really good at assessing capacity for refusals. But for hypoglycemia specifically, I'm going to offer you some criteria, which you could find these criteria like in EMS textbooks or other places that, and I cite one at the end where you can look this up, where you can find the criteria that are, if the patient meets all these criteria, they're more likely to be safe to refuse, and that's relatively safe, okay? So one, they have to have a history of diabetes. If someone doesn't knowingly have diabetes and now they have a blood sugar emergency, they should go to the hospital because they need to be diagnosed, and they need to find, the cause of that. Sometimes conditions like sepsis could lead to hypoglycemia. There could be other things going on. So you want them to have a history of diabetes. Two, they should return to normal pretty quickly after giving them sugar or dextrose or whatever sugar you have, right? Should be pretty quick. Like if it's taking longer than 10 minutes, maybe not the best person for a safe refusal, okay? The pre-treatment glucose had to be less than 80. So ideally, you've checked the blood sugar either via the patient assisting their glucose monitor or ALS have told you, and post-treatment greater than 80, right? You're basically showing that by giving them sugar, you made their sugar go up, okay? Number 5, really important. They have to be able to eat by mouth. If they can't eat by mouth, when you leave, they're just going to get hypoglycemic again because they're not eating, right? So they have to be able to eat, okay? Absence of comorbid conditions or other complicating factors. What does that mean? Well, remember on the last slide, I told you that often these emergencies are a cry for help for some other condition. So maybe they had a glucose emergency, but they were having their MI, or they're having trauma, or they don't have any insulin at home, so it's going to happen again. So if there's other complicating factors, you need to consider that, and maybe it's not the best for them to refuse if there are other comorbid conditions that would prevent them from being safe at home. They should have follow-up with a primary care doc. If they don't have good follow-up, they should probably come to the hospital and get checked out and get plugged in. Number 8 is really important. No sulfonylureas. Okay? Sulfonylureas put you at risk for recurrent hypoglycemia. There should be a Y in there. We'll add that little Y. Okay? Sulfonylureas, I'll give you a list of them on the next slide just so you know what kind of meds I'm talking about. But if you find on their medication list they're taking sulfonylureas, those medications can stick around and they can have recurrent hypoglycemia and a much riskier refusal, okay? They should have normal vitals too after you treat them with sugar. They should be able to understand the instructions, and they should have someone who can watch them, because if they get hypoglycemic again, they may get confused. They may not be able to give themselves sugar. Someone should be there with them to call for help or come back, okay? And this is just add on to your normal refusal procedures with decision-making capacity. And like I said, I've covered capacity in another video, so I won't rehash that whole thing here, but these are some extra things for hypoglycemic emergencies that can be helpful for you when counseling the patient and trying to decide if this patient is safe to stay or should go in, okay? Now, in general, I'd recommend that they go, but if they meet these criteria, it may be reasonable to have them refuse. Like if they really want to refuse, you could feel that this is pretty safe if they meet all these criteria, okay? Now, I mentioned sulfonylureas can cause problems with recurrent hypoglycemia. So these are the common medications. The most common 3 I see are these ones here. Notice how they all end in "ide." So glipizide, glimepiride, glyburide. These ones here are a bit older. I don't see them as much out there anymore, but you might find them. So just to be aware of them. And if you're in doubt or not sure, you all have smartphones now. Google the medication and see if it's a sulfonylurea. Okay. But the top 3 that I put on there, I think are probably the most common that are still out there right now. But there, like I said, there are others. If you're not sure, everyone's got a smartphone now. Put it into your phone and find out if they're on a sulfonylurea or not. Okay. That's all I got for you guys this time. If you guys want to check out that textbook I mentioned on diabetic emergencies, this is a really good emergency medical services reference text. It's the one we use to train physicians in EMS. So feel free to check it out if you're interested. Don't hesitate to reach out to me with any questions. Happy holidays, and see you all in the next one.